First 5 centimeter, there is 15 to 20 centimeters cervical esophagus, and next 5 there is 20 to 25 is upper thoracic, and 25 to 30 next 5 is middle thoracic, and 30 to 40 is low thoracic. So 5, 5, 5, and 10 that we have to remember. The esophageal gastric junction cancer with epicenter within proximal 2 centimeters of cardia, that is severe type 1 and type 2 are staged according to the esophageal cancer, and severe type 3 is staged and treated as per the treatment guidelines for the gastric cancer. This video tutorial has been divided in the following heading: introduction, brief anatomy of the esophagus, TNM staging, different lymph node station, 3-field versus 2-field definition, what are the changing trends of lymph node status according to the AJCC classification 6, 7, and 8, regional lymph node station according to AJCC and Japanese classification, what are the rationale for lymphadenectomy, arguments against and for 3-field lymphadenectomy, and the relevant literature review. So this is the distribution of lymph nodes in case of squamous cell carcinoma and adenocarcinoma. So we can see that in case of squamous cell carcinoma, the involvement of the lymph nodes in the thorax is higher as compared to the involvement of the abdominal and lower thoracic lymph nodes in adenocarcinoma, and the difference is significant in case of lower adenocarcinoma. For the preoperative lymph node assessment, the CT scan has pooled sensitivity of 30 to 60% for detecting enlarged lymph node that is more than 1 centimeter size. FDG PET CT has a low pooled sensitivity of approximately 51% in loco-regional nodal assessment, as nodes often get obscured by metabolic activity in the primary tumor. The US is highly sensitive, approximately 85% for assessing degree of the nodal involvement. Addition of FNA to US has shown the greater sensitivity and accuracy. In a study by Vasquez et al., they compared performance and characteristic of CT endoscopic ultrasound and US-GUT FNA for preoperative clinical lymph node staging in 125 patients. The US FNA combination was more sensitive than CT, that is 83%, 29%, that was significant, and the more accurate than CT, that is 87% versus 50%, again it was significant, and US alone, that is 87% versus 74%, which was not significant. The preoperative lymph node assessment PET CT role, the sensitivity of PET CT I said is low, but for detecting cervical, upper thoracic, and abdominal node, it's 78%, 82%, and 60%. The sensitivity is 38% and 0% respectively for the mid and lower mediastinum. As it has already discussed that the lymph node activity gets masked by the primary. Retrospective review by Keswani Arun et al. 148 esophageal cancer who underwent total nodal staging by USFNA and FDG PET. The addition of FDG PET did not alter the nodal staging in any patient with USFNA. So the gold standard for nodal staging is USFNA, then US, then followed by PET and CT. So what is the rationale for lymphadenectomy? Why we should do lymphadenectomy in patients of CS esophagus? As the transhiatal esophagectomy was the standard of care, so aim of extended lymphadenectomy for esophageal carcinoma is twofold. First is to accurately stage the disease. Second is to potentially cure the patient. This is a randomized trial by Halscher JV et al. I urge the viewers to go through this trial. This is a landmark trial. They randomly assigned 220 patients of adenocarcinoma made to distal esophagus or gastric cardia involving the distal esophagus. The lymph node yield almost doubled between transhiatal esophageectomy and versus transthoracic in block esophageectomy groups 16 and 31 respectively. Although the median overall survival, disease-free quality adjusted survival did not differ statistically in this group, in this study, there was a trend toward improved long-term survival at 5 years with extended transthoracic approach. The oncological outcome of lymphdectomy in THE versus envelope, the literature regresses riddled with problems of data compatibility between East and West, as we discussed already. In transhiatal lymphdectomy without formal lymphdectomy known to have higher locoregional recurrence, the recurrence rate of series of 149 patients in Hulster group, the local region only in 23.4%, systemic only in 15.3%, total local region recurrence rate nearly 40%. Of this majority, 49% occurred in thoracic field where no lymph node dissection has taken place. The envelope esophageal data from demister group shown an isolated local regional recurrence rate of 8% as compared with 23.4% in preceding THE series. In most published literature, local regional recurrence after transhiatal esophageectomy is much higher, that is 23 to 40%, as compared to envelope esophageectomy, that is 1 to 2%. So, we have now a good literature evidence, including randomized controlled trial from reputed institutes, which has shown the benefit of external lymphadenectomy in case of C. esophagus. Three-field lymphadenectomy, the history of cervico-thoracoabdominal three-field lymph node dissection started from the reports by Kinoshita et al. In 1976 and Senhoi et al. In 1981. They emphasized that the esophageal cancer had frequent metastases in recurrent region nerve nodes and in supraclavicular lymph nodes. Based on these two reports, many surgeons adopted three-field lymph node dissection for cancer in thoracic esophagus. So, the cervical field node dissection during three-field lymphodectomy for squamous cell carcinoma has shown a metastasis rate of 23.4 to 49.5%. In a series by Fizzuta, 750 patient three-field lymphodectomy, cervical lymph node positivity was 24% and cervical local regional recurrence was only 14%, which was quite low as compared to the positivity. So, the incidence of metastasis in regional lymph node was higher, and they have grouped, as seen in this table, that the incidence of recurrence in upper, middle, and lower, they have given right and left. So, for even the lower thoracic esophageal cancer, there were chances of metastasis to the cervical paraesophageal lymph nodes and 3 and 1 cases, as highlighted in the this red rectangle. So, these are the different series that cervical field dissection during three-field lymphodectomy or squamous cell carcinoma has shown a metastasis rate of 23.4 to 49.5%. Three-field and two-field lymphodectomy and long-term survival. Important landmark paper by Akiyama et al. Has shown that what three-field lymphodectomy can do for long-term survival in esophageal cancer patient. In this series, 707 patients of squamous cell carcinoma who underwent RU resection were analyzed, and 393 underwent two-field and 374 underwent three-field. The overall 5-year survival was 37.1% in K and versus 52.2% in two-field and three-field. The three-field lymphodectomy led to 25% 5-year survival in subgroup of patients with positive cervical nodes. Patients with squamous cell carcinoma and positive stage after three-field if they had more than 7 positive lymph nodes, they had lower survival rate despite radical procedure, that is 9% versus 51% 5-year survival. That showed that if the metastatic burden is high, then the extensive dissection, that is three-field lymphodectomy, may not be helpful for the patient, but definitely it was helpful for early stage, early spread when the metastatic spread to lymph nodes was less than 7 in number. This is another landmark trial by Nishihara et al., prospective randomized trial of extended cervical and superior mediastinal lymphadenectomy for carcinoma of thoracic esophagus. In this trial, they randomized 32 and 30 patients in three-field versus conventional. The 2-year survival was 83.3 versus 64.8. 5-year survival was 66.2 versus 48.48. Recurrence rate was 99.9 versus 24.1. The extended cervical and superior mediastinal lymphadenectomy may improve long-term result for carcinoma of thoracic esophagus. Since such cases were quite limited in the study, however, no definite conclusion could be drawn from this study. So, three-field lymphadenectomy and long-term survival. A series of by Tekimana et al. Three-field lymphadenectomy of squamous cell carcinoma from Japan. The 5-year survival was significantly different for N-positive stage in 1 to 4 lymph nodes as compared to more than 4 lymph nodes, and that was 37% versus 14%. So it has shown that three-field lymphadenectomy was of benefit or more benefit when the lymph node spread was to the lesser extent, that is up to 4, and in another study which we discussed previously, it was up to 7. In this Dutch randomized control by Omlo et al. In adenocarcinoma of THC versus extended embryonic esophagectomy, they could not demonstrate a survival difference even after complete 5-year follow-up, 34 versus 36%. But authors themselves considered that the sample size was small for the difference to reach. So, how many lymph nodes we should resect in case of C. esophagus? The Worldwide Esophageal Collaboration Group, WECC, collected their data in 2009. Total 7,884 esophagectomy of 13 participating institutions and 4,725 were neither proceeded nor followed by adjuvant treatment or radiotherapy. Using endpoint of all-cause mortality and advanced statistical method, optimal number of lymph nodes to be resected was defined for each stage. The authors recommended to maximize 5-year survival. A minimum lymph node to be resected was 10 for T1, 20 for T2, and 30 or more for T3, T4 cancer. WC data was used to establish the change in N staging proposed in 7th edition of AJCC TNM Staging for esophageal cancer. That is, now the N1, N2, N3 is based on the total number of lymph node positivity. Retrospective analysis of 4,822 patients in CA database. If more than 12 lymph nodes were examined, it significantly reduced the mortality compared to who had 0 to 11 lymph nodes examined. And more than 30 lymph nodes examined had the lowest mortality of any group. The NCCN 2020 recommends at least 50 lymph nodes submitted for pathological evaluation and adequate nodal staging in esophageectomy without perioperative chemoradiation. The optimal lymph nodes to be removed after neoadjuvant chemoradiotherapy is unknown. A recent study by Goa et al., the resection of 13 to 20 nodes was assured to be the improved recurrence-free survival and overall survival in patients with locally advanced esophageal squamous cell carcinoma receiving neoadjuvant chemoradiotherapy. The extended lymphadenectomy of more than 29 lymph nodes did not correlate with increased survival. A recent meta-analysis by Weiser et al., the survival benefits for increased lymph node yield from esophagectomy regardless of whether or not patient has received preoperative therapy. The NCCN recommends at least 50 lymph nodes for esophageal cancer who receive preoperative therapy. So it is 50 lymph nodes at least whether the patient has received chemotherapy or not. As per the NCCN guideline, we have to dissect for adequate lymphadenectomy and staging of the patient. So, what is the morbidity and mortality of lymphadenectomy? The major morbidity specific to lymphadenectomy is pulmonary complication. The major contributing factors are recurrent lesion of injury, tracheobronchial ischemia, pulmonary vagal degeneration, and poor pulmonary lymphatic drainage. The operative mortality ranges from 0 to 10%, and overall mortality ranges from 46 to 80%. The nationwide survey from Japan of 1791 patient and who underwent 3 lymphdectomy, the morbidity was 54%, pulmonary complication was 22%, recurrent linear palsy was 20.3%. There is a learning curve and 2 reports of in-block esophagectomy from a Demester group of 37 patients in 1999 and 119 patients in 2006. The operative mortality improved from 5.4 to 2.5%. So the outcome improves as the learning improves. So these are the different series of recurrent nerve palsy after extensive lymphadenectomy. The Japanese series, the incidence of recurrent nerve paralysis are similar in 3A2 field group, and left recurrent laryngeal nerve lymph node dissection done 14.2 versus 20.5%. In Dutch series, the RLN palsy was 22%, but most improved after 3 to 6 months, and only 4% had current palsies. Similarly, in Japanese series, three-field dissection, RLN palsy rate was 36% versus 36.2, and permanent palsy was seen in 12% versus 21.2, respectively. The quality of life studies have found persistent RLN nerve palsy to be associated with poor quality of life, poor pulmonary function, repeated aspiration, and pneumonia in long term. Or should we do a gyrus vein dissection during in-block esophagectomy or not? The retrospective clinical study evaluated in-block esophagectomy specimen 92 patient. The gyrus vein dissected from specimen and the lymph node along it were separated. The authors concluded a significant number of lymph nodes lay along a gyrus vein and it should be resected during esophagectomy to increase the lymph node yield. Study was criticized for the amount of tissue removed from specimen with the gyrus vein. It did not reflect the technique of minimal access esophagectomy very well. During minimal access esophagectomy, surgeon would bear a gyrus vein and leave hardly any tissue along. There didn't seem any real oncological benefit to dissecting gyrus vein during an esophagectomy in the minimal access or open surgery. So the present consensus is we should bear all the tissue along the gyrus vein, but the resection is not recommended during in-block esophagectomy. So what are the arguments for lymphadenectomy according to tumor site? Most experts agree that three-field lymphadenectomy procedure of choice for upper third esophagus. The consensus of experts in a panel during the 1995 International Society of Disease, International Society for Disease of Esophagus Milan meeting, also recommended by Japanese Esophageal Society guidelines of 2012. Disagreement on issue of three-field lymphadenectomy on middle and lower third. Japanese guideline suggests that cervical lymphadenectomy may be omitted in selected patients with middle or lower third esophageal carcinoma. They further suggest that for these groups of tumor, total mid-external lymphadenectomy should be done. High incidence cervical lymph node metastasis, that is 13 to 14% in upper one third and 14 to 15% for middle third, and upper and possibly middle lower third tumor should undergo cervical dissection. So, upper and possibly middle lower thoracic tumor should be considered for cervical dissection. The upper mediastinal lymph nodes, that lymph node metastasis, upper mediastinum in particular along the recurrent nerve, may be an indication for cervical lymph node dissection. So, if during the mediastinal dissection, if we find that there are tumor deposit in the tissue along the recurrent nerves, that becomes an indication for the dissection of the cervical lymph nodes. Otherwise, it may be omitted safely. The use of neck lymph nodes can be used for selecting the patient for cervical field node dissection. Cervical dissection is not recommended for palpable enlarged lymph nodes because there is a lack of survival. As we discussed already, if the tumor burden is high and if more than 7 lymph nodes in one study and more than 4 lymph nodes in another study were positive, there was a lack of benefit on the long-term survival even after extensive dissection. So, what are the arguments for lymphadenectomy? Skip meds. Skip meds, lymph node metastasis to distal lymph node station beyond immediately adjoining lymph nodes. can occur, wherein lymph nodes at the same level at primary tumor may be negative for the metastasis. As we discussed, there is an orthogonal spread because of the continuous lymphatic channel in the because of the esophagus problem next to the celiac axis. The incidence of mets is 20 to 73%. In a study by Hosh, SB et al., the incidence rose from 34 to 60% if ISC was used to detect micrometastasis. The importance of skin metastasis lies in missing out lymph node mets and understanding the tumor if formal lymphadenectomy not done. The carcinoma G junction, the genital carcinoma extending more to the esophageal side. That will be like severe type 1 and type 2. Then to the gastric side, right thoracotomy with dissection including the upper mediastinal lymph node is recommended. For case of G junction extending more to the gastric side than to esophageal side, that mean severe type C, the metastasis to mediastinal lymph node less frequent and dissection of these lymph nodes is lesser consequences. In my opinion, the current literature suggest or bias toward the extensive lymphadenectomy and three-field lymphadenectomy. So rest I leave up to the viewers to decide. So now we have reached to the conclusion that there is a repeated appeal of effectiveness of three-field lymphadenectomy by Japanese surgeon. Three-field lymphadenectomy has not been accepted worldwide as a standard of care for thoracic esophageal cancers. There are lack of randomized control trial and is one of the largest criticism of three-field lymphadenectomy. It seems difficult to make three-field lymphadenectomy world standard even if there are RCT with positive result are made because there is inherent resistance or say inertia in the minds of surgeons. The essence of three-field lymphadenectomy has revealed the fact that bilateral cervical paraesophageal and bilateral supraclavicular lymph nodes are regional nodes for thoracic esophageal cancer and not metastatic as being recommended in AJCC 8th edition. To let the world admit this essence should be the real endpoint of three-field lymphadenectomy. This will be the message from Japanese center to the rest of the world or Western center. While we are stranger, what we talk about may sound like a myth, but after we know each other, data will talk, and I think it should be the real endpoint of three-field lymphadenectomy issue without randomized control trial. So thanks for watching, viewers. This was a bit lengthy video, but this is very complex and important topic, and most of the time it puzzles the mind of students and budding surgeons. So we have covered everything in detail. I hope you have enjoyed the video. Thanks for watching. Please don't forget to like the video and subscribe to our channel and hit the bell icon for future important updates. The channel subscription is free for lifetime and knowledge is invaluable. Happy learning and thank you very much.